community screening for glaucoma, is it viable? We all know it's not a very easy disease to screen because of various factors involved: intraocular pressure, optic nerve changes, visual field changes, gonioscopy. So it's always a challenge to do a community screening, where the prevalence is not very high, but still we need to find the people at the right time. So Madam will be talking about how we can make it viable.
Actually, community screening is a very gray area of this thing. And if you look at the national program NPCB, the word, truly the glaucoma itself was not there at all. And now they're having a certain amount of sort of, that is also there, but there is really nothing about it. And it's a really challenge. We have a huge population. So magnitude, I won't talk because Pawan has already talked about it, but only one word I would say. As on today, the Indians over the age of 35 are 45 crores. And if we take a simple of 2%, that means we are dealing with 90 million people, which is a huge number, and that is only the glaucoma patients. And if you look at the suspects, it's a huge number, and we have reached a level, then we need to really do it. So how do we do it? This cannot be just a government baby or anybody's baby. It's got to be our baby, right? So we'll be talking about this. So exactly what is the screening is, that is a presumptive diagnosis. We want to catch people before they really get it. So the three kind of ways we do it: the mass screening, we do opportunistic screening, and also we do selective targeted. So some people are doing selective targeted. Opportunistic is actually the way it's going on right now, but mass screening is not the gray, I would say, is the darkest shade of gray. So why do we really need it? I think we all know it here, being glaucoma people, that is irreversible visual damage. Therefore, we got to pick up and nip it in the bud. And unless until we do that, we cannot get good results. So what do we get out of it? We get early diagnosis, we can prevent it, we can enhance the quality of life, and also if we save this, we save the working man years, which are extremely important as far as the economy of the country is concerned. So if we can actually put in the head of the people that is the economy which will be affected, then probably it will sit somewhere. So what do we have in the evidence? The worldwide evidence is the Sightsaver study, in which they used three methods: IOP, questionnaire, and FDT. The disc was missing, and the thing was that even if you put IOP, FDT, and questionnaire all together, you're getting only 88% sensitivity and specific 57%. It's not really worth it. So this failed, and this was not really worth it. Another study was the Blue Mountain study, in Australia. They used HRT. They found 40% they could detect, but they also had people who were 200 to 400% people who did not have glaucoma were being detected. So again, this was a disaster. So current prevalent methods in India, we don't really have any glaucoma program, but if we say that nothing is happening is also not true. The cataract camps are going on, just cataract camps. Some camps are comprehensive, and some people are still targeting and experimenting, actually flirting with the ideas as to what we can do. As Venkatesh said, we are using fundus devices, we are using this, but there's not concentrated, and it's not as a program. So come to standard cataract camps, the torchlight camps, which practically even non-operating NGOs doing it, and they're doing a torchlight exam, getting cataract patients. IOP is found high. They call them glaucomas. Disc evaluation is usually not done. Second is these door-to-door screeners. And basically, it is the IOP that is the code word. Some people do screen disc, and they find anybody with that, and they take care. So that's a very small number. Out of cataract, if you have it, you have it. But we know people are far beyond that. Comprehensive camps are a good bet. At least they are seeing AC depth. So we are having some idea. IOP, disc evaluation by direct or indirect, depending upon the capacity. And we are flirting with many ideas right now at the moment, actually, using the camera for the camps, for the mobile van, for the vision centers. But only challenge we are facing right now is the training of HR, because you use residents, you use fellows. This is a changing population, but we really need to have some people who are focused and only for that job. Getting people for that job is difficult. And in the targeted, what we can do is, what we're doing right now is that vision centers and mobile vans fully equipped with mobile fundus camera. Venkatesh has shown, and we are having a joint program with the handheld camera actually, which is pretty good. Along with the FDT doesn't really work, but either a iPad-based or a virtual reality one goes with it. Along with cataract cams, this is another viable way. So what experience world had was not nice. They said it's not really viable, cost effective. Chinese people said that it is viable, but lots of caveats. It's a full article. If you read that, there are too many caveats, and to me, it did not really look viable and understandable, this thing. In India, we have a model. It was by Dr. John, that but this model is a model-based study. They have taken cost from Eastern India, one of the NGOs or somebody, model from the programs which are in the literature, and based on that, and they've taken prevalence from Chennai glaucoma study. So from that, different, you put a nose, mouth here, whatever it is, we have to experiment, it might work. And what they found was that cost was about 7.25 thousand per patient. And if this model really works, it's good. But caveat here is that will the people be ready to pay? In the rural India, paying population is pretty much poor is what we see around our area, and which is a large catchment area. But most important point here is, again, HR, cost effectiveness and all is still money can be managed, infrastructure can be managed. But people who will get trained and who will stay with you is still a huge challenge. So challenges I've already talked about. This is just a slide. I'll move, but what we really need is the concentrated HR infrastructure, a program, a teleophthalmology, stroke and AI. So can we sit down like this that, oh, it's too difficult, we can't do it? Not at all. So we need to work. Here, this is our role comes. In this government probably can't have so much of it, but competent HR, infrastructure, where we provide all these things for the cataract camp, because cataract camps are viable camps. They generate money. So with that money, partly we utilize for this. Only thing is that we are not adding that in the cataract camps and comprehensive camps. It's a strategy. If we have a proper strategy, minimum required this for screening you need to do for glaucoma, then probably we can make it reasonably viable. So what we are trying now, we are experimenting with this. We don't really have a major data as now, so I'm not presenting data, but a van which has got everything. And this van goes for cataract camp, which goes for a comprehensive screening, but we are getting a lot of glaucoma suspects whom I'll tell you exactly how we are getting back to hospital, because just tell them to come, they don't come. But all the patients who are cataract or actually having frank glaucoma, they are brought back. These are the two fundus cameras that we use, the Remedio and that I like. The camp has the same protocol as van. And this is the AI fitted in the camera. It's a very basic thing as on now. So it's a project that doctors, optometrists are assessing on one arm, AI is doing on the other arm. We'll know result in, I think, an year or two, that exactly what can AI do, and whatever AI is not able to do, the doctor's assessment will be added to that, and then we'll probably have something really worthwhile. So funding agencies, very difficult to find really people. Somewhere down the line, we all have to rise and shine to this thing. Stand alone by anybody is a distant dream. But put together, if we all join together, I think we can do it. Sandeep Buttin says that if we see all the patients and refer them, but when you refer them, they don't come. All those who are sitting here, we probably will know that if we refer 100 patients, 10, 15 will land up, 90% will not land up. That's another challenge. So possible, viable way would be that we advocate to the government that in whatever way you can do it, please start at least that much. All of us get down and train our whatever manpower we have, whosoever we get, instead of thinking that this will stay or not stay, just train somewhere, the person will go and work. We have one program which everybody put together makes one program, and everybody countrywide follows the same program. Maybe like Arvind, people can do that. That's a followable program. And let's have an algorithm as to how can this program and the data by this can be used into a more effective manner. So ACD, IOP, Van Harix, and this, if we have these 4 parameters along with a few questions, I think this will be almost 95% CAI. Regarding viability, so it's HR, technology, and this thing, and funding. But if we add one arm, innovation in it, the innovation is innovation actually which will get the screening into an effective mode. So all the innovative devices and this is what we had not this thing. This is, I don't call it actually awareness, I call it advocacy. So we have trained about, say, 8,000 ASHA workers across the districts. And it's not one day. They are into advocacy mode because they're living in the villages. So on very regular basis, they're putting in the head this that you have to screen for glaucoma, you are more than 40 years old. So this is one arm which will prepare them mentally to come to hospital, as well as come to camp or wherever is possible to get themselves screened. So with that, all I would say is that best hope is that an augmented comprehensive approach which involves government, NGOs, practitioners, and practically every citizen of this country, only then we can move somewhere with a proper screening protocol. Whatever infrastructure is available, I would say even a short tonometer is not a bad idea if you don't have a good tonometer for the camp. As long as everybody who comes to campus, at least tonometry is done, a disc is seen, direct is pretty cheap, if not a slit lamp. So we do what we can and put together, I think if we put all of them together, we can reach somewhere. Thank you.
Thank you, madam.
So we can't give these beautiful red and yellow capsicums, but we can give this side of things to our people, which are very much available.
I think you rightly nailed. I think it's the sensitivity which is very important for screening, but the problem is many of these put together also you may not have a very good sensitive screening tool, but even if the specificity is low, it's fine. You may have a lot of false positives coming, but at least we may not really miss the true diagnostic glaucoma patients in a camp. So we need to find a way of kind of compiling all this to make our other screening programs. It may be diabetic retinopathy, cataract screening programs, and whatever way we have to reach. And that's where opportunistic screening is very important. I